Medurstand. Understanding medicine.
I'm Professor Aziz-ur-Rehman, and today we are going to take up this another tricky subject called anion gap. I remember from my student life that it was a difficult concept. Many students had difficulty first comprehending it and then applying it. It is still not very easy, but I think I will be able to give you some insight, and I hope that you will be able to apply this concept better on your patients. First, I think some basic concepts behind this anion gap. Positively charged ions, which are called cations, must equal negatively charged ions, which are called anions. In body, we have positively charged ions and we have negatively charged ions. And body always makes sure that their level remains equal to maintain electrical neutrality. So there is a mechanism to make sure that both are kept equal. If one is increased, obviously due to some disease process, the other on the same side may decrease to maintain the balance. For example, if one anion is increased, the other would decrease automatically through some homeostatic mechanism to keep the total anion level equal to cations. All cations and anions are not measured routinely. If we had measured all the positively charged ions and negatively charged ions, then this concept will not be applicable. Then we will know individual anions or cations if they are increased or decreased, and accordingly we will build up our differential diagnosis. Since some of the cations and anions like sodium, potassium, chloride and bicarb, they are measured routinely. When we send sample for serum electrolytes, at least traditionally, these are the four ions, two cations and two anions, which are measured. So the other which are not measured, we try to make an idea if they are within normal range or if they are disturbed. From the mismatch of commonly measured cations and anions, we guess the unmeasured ions. Okay, so that is the whole theory about this anion gap. And once we go through this presentation, I should be able to make my point more clear. Now this is the equation. These are positively charged ions, mainly sodium and potassium, but there are some other positively charged ions which are not routinely measured. Calcium, magnesium, they can be measured, but they're not included in serum electrolytes. And on this side, we commonly measure bicarb and chloride. There are many other anions which are represented by this green bar, which are not routinely measured but can be measured. Okay, so whatever we measure, sodium and potassium and bicarb and chloride plus this unmeasured ion, they must equal according to this equation. And this is the formula. The traditional formula is that anion gap is sodium plus potassium, both summed up, and then chloride and bicarb summed up. So from total of sodium and potassium, you subtract total of chloride and bicarb, and the net figure would be called anion gap, and that is what is represented by this green bar. And if you take sodium and potassium, this is traditional equation. In that, sodium and potassium both are taken into account. So the normal value of anion gap would be 8 to 16. All right. But in the newer concepts, they do not measure potassium. They do not include potassium in calculation. Now, in that case, the equation will be slightly different. Both columns have slightly reduced in size because potassium is not included. So we just include sodium here, and the equation will be like sodium minus chloride and bicarb. So the total number has reduced from 8 to 4 and from 16 to 12, which is the average level of potassium, which is around 4. This may be convenient because you don't have to consider potassium, but in some cases where potassium is significantly deranged, like renal failure, then I think the traditional concept may be better. So what happens is we have just mentioned that these positively charged ions, this and including unmeasured cations, and these anions plus these unmeasured anions, they should equal to maintain this balance. So if this is increased, which we don't see, if this is increased, the anion gap is increased, which we don't see because we don't measure these anions. So because of the compensatory mechanism, this should reduce. We measure this and this is routine. So if there is disparity, there is a certain disparity normally, which is represented here. But if the gap between all positively measured ions and negatively charged measured anions, if the gap is increased, that implies that this is increased. Now this is I'm going to show in the form of graphics. Please concentrate on these graphs like this. See, we know that this is reduced. We know this is reduced. We also know that this total and this total should be equal. So this is reduced. This must increase. So actual problem is increase this one. What we imply from this reduction of this. So this gap will be increased. So this figure will become more. From 8 to 16, it will become more. Like it could be depending upon the insult, it could be 20, 21, 22 or even more. So to recapitulate, we measure sodium, potassium, chloride and bicarb in routine serum electrolytes. We do not measure this gap because they are many and they need specific test. And from the routine electrolytes, if this gap is increased, the inference we draw is that one or more of the unmeasured anions are increased. So then depending upon the clinical condition, we have some idea which are those anions. So depending upon which clinical condition is present, we measure those anions specifically. These are the ones. Albumin is actually not an electrolyte, but that is negatively charged protein in body at body pH. It is negatively charged mostly, but organic acids, phosphates, lactates, these are represented by this anion gap. And the clinical condition, which I'll discuss in more detail later, but diabetic ketoacidosis, where ketone bodies are accumulated, renal failure, where many acids are accumulated, liver failure, and then aspirin poisoning and other poisoning. Because this is increased, as a result, this becomes short and the gap is increased, and we make a diagnosis of wide anion gap, usually in metabolic acidosis. Theoretically, there are conditions where you can have increased anion gap, high anion gap, or you may have condition where there is acidosis, but anion gap is still normal, and I'll explain how. Then there are conditions where anion gap may be low. These conditions may not have acidosis or alkalosis, but they are important conditions. First, this is the easy one. So let's take this one first. If there is loss of chloride and bicarb from the body with simultaneous loss of sodium and potassium, let's assume patient loses bicarb, chloride and sodium potassium proportionately, like one would develop dehydration as a result of chronic diarrhea. Then patient may have acidosis because of net loss of bicarb, but patient will not have any effect on the anion gap, because one side of the equation there is sodium and potassium, they are lost. On the other side of the equation is chloride and bicarb, they are also lost. So both positively charged ions, cations, and negatively charged ions anions from the normally measured electrolytes, since both are lost approximately proportionately, so there will be acidosis, but there will be no normal anion gap. So these are the conditions where anion gap may be widened. Any of the unmeasured anions are increased. In the next slide, I'll show those ones. Then if there is hyperalbuminemia, albumin at body pH, normal pH, is mostly negatively charged, so that will be counted as anion also. Then any of the unmeasured cations, if they are reduced, if these are reduced, since we are measuring gap between cations and anions, if any of the anions are increased or if any of the cations are reduced, they would have the same effect. So potassium, magnesium or calcium, if they are reduced, they would have the same effect on anion gap. Anion gap will be widened. Now let's see those conditions where anion gap may be less than normal. Any of the unmeasured cations are increased. Patient with potassium hyperkalemia, for example, hypermagnesemia, hypercalcemia. There are very important clinical conditions where there could be these. For example, in renal failure, you could have hyperkalemia, you can have hypermagnesemia also. And there are conditions where there is hypercalcemia, hyperparathyroidism, vitamin D intoxication. So these are important conditions. These levels may be increased. In these conditions, we normally specifically measure these cations, but from the normal electrolytes, you can have an idea that anion gap is narrow. Maybe one of the cation is increased. Then addition of lithium. Lithium, of course, is not present in normal humans, but those patients who are treated with lithium and their level is usually monitored. And in lithium intoxication, lithium is also a positively charged ion, and in other words, cations. So if lithium is added to the plasma, that will also lead to reduction in anion gap. Hypergammaglobulinemia. Like at normal body pH, albumin is mostly negatively charged ion. Gamma globin is positively charged, so it will act as cation, and same effect would be on the anion gap. Then hyperlipidemia. In people with massive hyperlipidemia, particularly hypertriglyceridemia, sodium is not actually measured. Sodium is underestimated, so that can also lead to low anion gap. Hypoalbuminemia. Since hyperalbuminemia is here, it's this opposite, hypoalbuminemia. And there are so many conditions where there is hypoalbuminemia, like nephrotic syndrome, like cirrhosis, like hypoproteinemia due to malnutrition. So all these conditions, anion gap may be low. So this is more or less theoretical situation. But in the next slide, I will show you the clinical condition where this anion gap is normal or widened. So wide anion gap conditions, acidosis. You know, when I talked about blood gases, and I told you that if you make a diagnosis of metabolic acidosis, then only concept of wide or normal anion gap will apply. So we are talking about the acidosis, okay? Renal failure. In renal failure, many anions, sulfates, urates, carbonates, they are all acids. They are accumulated in the body. Lactic acidosis, lactate. Lactic acid is also an anion, and that is accumulated in lactic acidosis. There are so many conditions, shock and sepsis and poisoning, where there could be lactic acidosis, ischemia. Then ketoacidosis. We confront with this condition very often. Patient with the diabetic or other ketoacidosis, there is production of ketone bodies. Acetone, butyric acid, acetoacetic acid, they're all acids. So when they are accumulated, anion gap is widened. And poisoning, like aspirin poisoning and other poisoning, there is also increased anion gap. So from normal electrolytes, if anion gap is widened, we will figure out one of this condition is present. Of course, If we take clinical context, you may be already suspecting renal failure. You may be already suspecting diabetic ketoacidosis. But from the electrolyte also you can figure out that one of these conditions is present, and then specific tests would be done. For example, if you suspect lactic acidosis, then serum lactate would be measured. Normal anion gap acidosis, that means bicarbonate loss from GAT. If somebody develops profuse watery diarrhea, patient is losing sodium, which is not acid or base, but patient is also losing bicarb, which is an alkali. So due to loss of bicarb, there will be acidosis, and there will be since bicarb and sodium are lost from both sides of the equation. Sodium is a cation that is lost, bicarb is an anion that is lost, so both are lost, so there would be no disturbance of anion gap. Renal tubular acidosis, again there's a condition where there could be acidosis with intact anion gap. So this is the clinical scenario where it is applicable. I think this was it. It is actually a short video. Let me give you the summary, and summary is also very short. Anion gap indicates the presence of some unmeasured anions from routine serum electrolytes. Serum electrolytes are done without even specifically suspecting something. If somebody is serious, we order serum electrolyte. That is included in the routine panel. So if somebody from the routine panel has got increased anion gap, you should suspect that there is some other problem, and taking clinical condition into consideration, further tests will be needed. So further tests depending upon the clinical condition, and clinical context is extremely important. I don't really think you can specifically figure out which particular anion is increased just from the anion gap. You have to know the clinical condition. If patient is diabetic, patient has got chronic kidney disease, or patient has taken some poison. So all these things have to be taken into consideration to be able to figure out the exact situation. Thank you very much. This is Professor Aziz-ur-Rehman from Medurstand. This was the third in arterial blood gas series. We first had arterial blood gases, and then we have spirometry, and this was anion gap. So I hope you listen to all three videos, and then you will be able to have some comprehension about this critical and very, very important concept. Thank you very much. Professor Aziz-ur-Rehman from Medurstand.